You're listening to Nitty Gritty Nursing with Nurse M, where she breaks down the nitty gritty basics of nursing concepts. Welcome back. I received an email from a future nursing student named Jessica, whose last name I'm not going to disclose, but in this email, she was asking for a few different topics to be covered. So today, we're going to take a deep dive into a rapid onset and potentially life-threatening condition that nurses need to be able to recognize it immediately, which is autonomic dysreflexia, which I'll be talking about. Now, I've also heard it called autonomic hyperreflexia. So depending on what resource you're reading, as well as what sort of materials you're provided by your university, you might see autonomic dysreflexia termed slightly different, but they're the exactly same thing. And this is one of those emergencies where the ability to think quickly and use your nursing judgment can really truly save a life. So let's kind of break it down and get to the nitty-gritty nursing of the interventions, the presentation, the evaluation, and education of patients that you would want to give going through this. So I'm going to try to simplify the pathophysiology and then tie it back to the PI, the presentation, interventions, education, evaluation. So hang in there with me. Let's first review some of the pathophysiology. If we review what the autonomic nervous system does, and we're doing that because this is autonomic dysreflexia, the autonomic nervous system is essentially a component of the peripheral nervous system that helps to regulate the involuntary physiologic processes. And these sorts of processes include the way that the heart beats, so it includes how our heart is beating, what our blood pressure is doing, how our respiratory drive is operating, and how we digest food. And this is because that autonomic nervous system really contains three distinct divisions. Those three divisions are the sympathetic system, which everyone is most familiar with, right? That is the fight and flight phenomenon that we talk about. The second system is the parasympathetic system, and that is where you've probably heard it termed as the rest and digest system. And between those two, being the sympathetic and the parasympathetic, they are what everyone is most familiar with. Now, in the autonomic nervous system, though, there is a third bonus division that is called the enteric system. And the enteric system is specific to the various controls in our gastrointestinal tract that we need. I break all of this down, and I say this because if we're going to talk about autonomic dysreflexia, we know that it is going to directly affect the autonomic system based on the name, and the dysreflexia, by definition, just means an abnormal or an overreaction. So in this particular complication, this is occurring from a spinal cord injury or lesion, usually at or above T6 in your spine, which for perspective, just envision this with me for a moment. If you're looking at someone's back from their, you're looking directly at their back, the sixth thoracic vertebrae, T6, is essentially located at the bottom of their scapulas. And what happens is that there's some sort of imbalance of the autonomic system being either the sympathetic or the parasympathetic divisions that causes that overreaction, which is what we see and how it sort of manifests. If we scroll back even further, because you really have to have a foundational knowledge to be able to understand what we're looking for in autonomic dysreflexia with our patients, the sympathetic nervous system, right, that is responsible for activating the fight or flight mechanism, which means that when you are suddenly scared, and the scenario that I was always provided was, the bear suddenly comes running at you. Our autonomic system, which is on autopilot, automatically engages the sympathetic nervous system. And so our pupils will dilate to allow more light in so that we can see more around us, like the dangerous thing that is coming at us. The blood vessels in our skin will also vasoconstrict, and it does this in order to redirect or funnel the blood back into our deeper muscles to allow us to be able to fight or run away quickly. So when this happens, our skin, for example, becomes pale. Our airway also opens up more, and that allows for more oxygen to be able to be exchanged and enter our system because we need the oxygen for our muscles, for fighting or running or whatever it is that we have to do to survive. And our heart rate goes up in order to perfuse that additional oxygen in our system that we need for the fight or the flight. So that is the sympathetic nervous system. Our pupils dilate, our peripheral skin blood vessels vasoconstrict, so we end up with pale skin, but we are redirecting the blood to the major organs to be able to complete the fight or fight. We open up our airways to increase oxygen, and our heart rate, we become tachycardic in order to perfuse said oxygen. Now, the flip side of this is our parasympathetic system. This is the rest and digest, and this is responsible for the resting of the body. This means that when our parasympathetic system activates, it slows our heart rate down to decrease the body's metabolic demand gland. And as a result, it decreases our blood pressure because we are not activating and vasoconstricting. Our breathing also slows down as well. Our digestive processes increase, and so we have some vasodilation to increase blood flow to the intestines to work on that digestive absorption process where we have to break down the food, absorb the nutrients, etc. And our pupils will also constrict to allow us to focus on things that are more close up, like after you've had a big turkey dinner, most people go and they sit on the recliner and they watch TV, or they read a book or something like that. So when our parasympathetic system activates, it's helping our body go into a restful and digestive stage to be able to consume or absorb the nutrients that we need by increasing with vasodilation the blood flow to our gut to absorb those things, slowing our breathing down, slowing our heart rate down, and allowing our pupils to constrict so that we can focus on things more closely. With that little review, let's tie this all back to what's happening in autonomic dysreflexia. Because at the root of the problem, there's just an event or some sort of catalyst that causes the autonomic dysreflexia to occur. Now, normally, this is from some sort of noxious stimuli. And if you look at all of the cases, roughly 85% of the time, the reason why someone is developing autonomic dysreflexia is due to the bladder. So either there's like an indwelling catheter that has a kink in it, there's some sort of bladder irritation like a UTI, or even bladder retention, so someone can't empty their bladder, right? That would, if you go back to the indwelling catheter, it can just be from the catheter, but if there's a kink and urine can't get out, it will trigger the bladder to retain that urine. And in most of the other cases, it's usually caused by the bowel, and specifically some sort of visceral distension, like the patient has a fecal impaction in the rectum and the colon is having to stretch. So by either having the bladder or bowel distended, for example, those stretch receptors in these organs trigger an exaggerated signal that then wants to get to the brain to tell the brain, hey, we have a problem. And that's usually, think about when you have to go to the bathroom yourself. There's something occurring in those visceral organs that is sending a message to your brain that says, I need to find a bathroom quickly. Irregardless, right? Now, regardless of whatever the structure is that's causing the problem, that signal that the organs are sending, it gets sent from the periphery or whatever organ it's from, and it goes to the spinal cord. It then tries to travel up the spinal cord, but gets stopped at the level of injury. And because that signal cannot get through the injury to get to the brain, that signal starts activating this and stimulating the sympathetic neurons specifically at the location of injury. So if we remember now that the sympathetic nervous system, and we remember what it's responsible for everything that we just discussed, the neurons that stimulate at that point of injury start sending out sympathetic or those fight or flight signals to all of the structures below that point of injury, because it's activating in the spinal cord the sympathetic neurons. And they start sending out fight or flight signals to everything south of wherever that injury is. What this means is that the blood vessels in the skin, again, they start to contract and redirect blood deeper into the body, which increases the blood pressure. And this is actually the first sign of autonomic dysreflexia. It is the increased blood pressure. But now, and it's not just redirecting the blood and only being hypertensive south of the injury, it's to the entire body. But at T6, that sixth thoracic vertebrae, it is redirecting the blood, and the hypertension is going everywhere. And our carotid arteries in our necks have pressure sensors in them called the baroreceptors, and they are very smart. So while the body has a stimulus from most likely either the bowel or bladder trying to send a signal up to the brain that gets completely stopped at wherever that injury is at T6 or higher, that injury location and the neurons in that location, the sympathetic neurons specifically, they start to throw a temper tantrum, and they start to stimulate the sympathetic neurons. They send the fight or flight signal to everything below the injury. It increases the blood pressure suddenly and very quickly because everything is now vasoconstricting and increasing that blood pressure because it thinks that there's a problem. And the carotid arteries, they sense this sudden rise in blood pressure, and being the responsible party here, they then tell the brain that the blood pressure has suddenly increased and that it needs to lower this. So this patient can just be laying in bed completely still, have, a T6 or higher injury, have a bowel or bladder or some other sort of noxious stimuli activating their system to try to send a response to the brain, and it can't get there, and they suddenly spike a blood pressure because there is a temper tantrum by the sympathetic neurons at the point of injury, sending a message to everything below, okay? The carotid arteries, again, sense that, tell the brain, hey, fix it. There's something needs to happen. And the brain is still intact. It says, yeah, no problem. I know how to fix this. I know how to decrease the blood pressure. I'm going to do this by lowering the heart rate. And it does that through the vagus nerve. Now, that vagus nerve acts as the parasympathetic nervous system, and it tells the heart to slow down, because if we can decrease the heart rate, which is the second most common symptom for someone having autonomic dysreflexia, we are going to thereby decrease the blood pressure in the system. So the rest-digest reaction of that parasympathetic nervous system that we get is activating above the level of injury that's being stimulated by the brain to counteract that fight or flight response that is being activated below that injury. So to make this abundantly clear, there's some sort of noxious stimuli, and it's more often than not the bladder or the bowel. It sends the impulse up the spinal cord to tell the brain we have a problem, and it cannot get through because the point of injury is a roadblock. And they start to throw a temper tantrum at that point, which activates the sympathetic nervous system that starts to send fight or flight signals to everything south of wherever that blockade or that point of injury is. Now, that increase in blood pressure gets recognized essentially by the carotid arteries with those pressure sensors that it has, and it tells the brain, fix the problem. The brain says, yeah, no problem, and it starts to stimulate or activate the vagus nerve, which vagus nerve just means wanderer, right? And the vagus nerve triggers the parasympathetic system to respond. So if you draw a spine out and just point that point of injury at T6 or higher and just color in everything south, that is a sympathetic response, that is fight or flight. Everything north is a parasympathetic or rest digest response. The other component that the parasympathetic system does, as it originates above that level of injury, with the brain trying to lower that blood pressure, and it's not successful, okay, is that it is also triggering the specifically facial nerve number 7, right? Because everything north of the injury is going to have a parasympathetic or that rest and digest response. And it triggers that facial nerve number 7 to relax the blood vessels in the head as a mechanism to try to lower the blood pressure. When it is relaxing the blood vessels in the head, it results in the patient having a flushed face because it is causing vasodilation, right? You're increasing the diameter to lower the pressure of the vessels in the head. But when you do that in someone's head, which is super duper vascularized, you are going to cause a headache. And so not only do they have a flushed face from that vasodilation, they also end up developing a headache and they start to sweat. So that is sort of the trajectory and what is happening. If we understand what is happening, let's take that back and look at the pie. So the presentation. How is someone going to present with this? How will this patient look? And if you remember now that wherever that point of injury is, for autonomic dysreflexia specifically, we have a sympathetic response south of the injury, and we have a parasympathetic response north of the point of injury. So south of that injury, we end up with the severe hypertension, and it's sudden. It is sudden severe hypertension, often with a systolic being like greater than 200. It's massive. And it's doing that, the reason why that blood pressure is so high is because the vasoconstriction of the peripheral skin and vasculature to redirect the blood flow, because it thinks that it needs to activate the fight or flight system, results also with pale, cool extremities below that point of injury. So we have, potentially pale arms, we have pale legs below the point of injury, they're cool to the touch, and we have severe hypertension. In that same process, right, we have the parasympathetic attempted relaxation response to counteract the hypertension. And what happens with that is the vessels in the head vasodilate. That means that the person ends up developing a very flushed face and sometimes even neck with a concurrent throbbing or pounding headache that comes on suddenly as well. And the heart rate drops and they become bradycardic. They also will have sweating and nausea occurring because of the entire autonomic mismatch that is occurring. Oftentimes, there's also some component of anxiety, or patients will say that they feel off, or they're having those feelings of restlessness or apprehension. We call this, the impending sense of doom. They don't understand what's happening necessarily, but something feels off. And the reason why they have sudden hypertension that's greater than 200 with pale lower extremities below wherever the injury is, a flushed face with a pounding headache and bradycardia with associated sweating and nausea, right, is because What has triggered this response is some sort of noxious stimuli. Again, 85% of the time it's from the bladder. And then there's a huge component from the fecal impaction. There are other things that can cause it, but either they have a full bladder, maybe they have an indwelling catheter that's been kinked or blocked, and it's now no longer allowing the bladder to drain. Maybe they have fecal impaction, so the visceral organs have expanded and they're trying to send a message to the brain to get the brain to pay attention to that. But it can also just be from tight clothing. So if they can't feel right below the point of injury and there's some really tight clothing, think about when you are wearing a pair of really tight socks, or if you do any sports and you have to wear, knee-high socks. If that elastic is too tight, our skin starts to send a message to our brain to tell us like, hey, this is uncomfortable, right? So it could be from tight clothing. It could be because of a pressure ulcer that's developing, or some sort of very painful stimuli that the cells understand to be painful, but that the patient may not feel because they have a spinal cord injury. So we're looking for the noxious stimuli that causes that response. Now the intervention of what are we going to do about it? What should nurses do immediately? So long as it's approved, they're not like still on spinal precautions. What we should do is sit the patient up. It helps to like a high Fowler's position. It helps to lower the blood pressure, right, with the gravitational pull a little bit. And we have to, at the end of the day, the biggest thing you have to do is you have to find and look for any and all potential noxious stimuli that is causing the issue for the patient. So that means we're looking at their clothing if they still have clothing on, but if they're in hospital, they probably just have a gown. But sometimes the ties of those gowns have like a knot on the string where you're supposed to tie it in the back, and that can slip under a patient. And if they are not mobile, that can actually start to burrow into their skin, and then you notice that it's a really red spot. So we're looking for the potential for a clothing issue. Check the bladder. Look for kinks in the catheter tubing. Bladder scan them because maybe they're retaining, right? And they need to have a straight cath done. Check for bowel impaction. So if you've assessed the bladder and the bladder is not the cause, check the bowel because it's the second most likely culprit. So when was their last bowel movement? Have they been dehydrated? Are they constipated? And we're monitoring their blood pressure like every 2 to 3 minutes. If you cannot find that noxious stimuli, you have to notify the provider immediately because the symptoms are not going to resolve, right? And what we need to medicinally try to help control that. So we're going to administer hypertensives if they're ordered. And typically those antihypertensive are short-acting agents because it's the noxious stimuli that you were potentially unable to find is what is causing the trigger of that sympathetic response south of the injury. And so it's short-acting agents like hydralazine or even nifedipine. Because remember, the longer the blood pressure stays elevated, right, we want to drop it because a sudden increase in a systolic greater than 200 is a problem. The longer that stays elevated, the higher the risk that the patient then has of some sort of brain damage because it can break a vessel and then we have a hemorrhagic stroke or it can cause a seizure. So we have to be able to control that blood pressure and that heart rate. So we might have to potentially give them something to increase their heart rate because their blood pressure goes sky high, and in an attempted compensatory effort, the blood pressure or the heart rate drops. So we have high blood pressure, low heart rate. When you go to evaluate your patient after all of this, the question that you have to ask yourself is maybe you found it and you realize, oh, the Foley catheter was kinked, or they had urinary retention and you had to straight cath them because you were astute nurses and you saw that the blood pressure suddenly spiked. You bladder scanned your patient and it said 660 on the bladder scan, and you had an order for a straight cath and you were able to drain the bladder, and then their symptoms go away. But what we're evaluating is, does that blood pressure that was the first indicator, does it return to baseline? Was the trigger identified and removed? So it could be that depending on the sheets, or if you use like a draw sheet, it could be that there's a roll that is causing a stimulus to the cells on their skin that is making that trigger occur. So maybe we have to flatten out the draw sheet a little bit so that there's no curls or bumps or lumps that are poking into that patient's skin causing that irritation because they can't feel it with a spinal cord injury. So we're looking to see, did we identify and remove the trigger? Does the blood pressure come back down to baseline? Are their symptoms resolving? So is the skin flushing that they have in their head and neck, is that going away, and is their skin returning back to a normal color? Is the bradycardia that they had, is it returning to a normal heart rate? that headache? Did the headache go away when the skin flushing went away? And ultimately, we are trying to evaluate whether or not this patient is stable with normal vital signs post-intervention of whatever that intervention was. Oftentimes, in terms of education, we really have to teach the patient and the caregivers, especially if they're going to go home, right, with some sort of spinal injury, about the early signs to watch for, which is that sudden blood pressure spike. We've got the bradycardia, we've got flushing of their face, headache, sweating. There's the 5 big triggers, or the 5 big symptoms, not triggers, but symptoms. Sudden hypertension, right? Flushing of that face with a subsequent headache, that bradycardia, and sweating. And we teach them, we educate the patient and also the caregivers on how to avoid triggers, like keeping the bladder emptied. So if they don't have an indwelling Foley catheter and they're straight cathing at home, we need to teach them that if you suddenly have a headache or a sudden blood pressure spike, right, or flushing in your face with a headache, that those signs and symptoms you need to evaluate, like, oh yeah, I have not straight cathed myself for 6 hours or 8 hours, so keep the bladder emptied. Bowel regimens are so crucial. Maintaining bowel regimens to ensure that these patients don't get constipated is huge. We're checking the skin daily, looking for pressure sores or ulcers that potentially could be developing that would then result in being the noxious stimuli as well. And then we want to encourage these patients to always carry a medical alert card, specifically for autonomic dysreflexia, and reinforce to them and their care providers when to seek emergency care. Because if they have that sudden rise in BP that doesn't go away, with even associated neurological changes, we now have to worry about the potential for maybe there was a blood vessel that broke in their head that is now causing some sort of hemorrhagic stroke, or there's just increased ICP or neurochanges. So anything like that, the more information and education we provide patients and caregivers, the more power we give them with this knowledge to advocate for themselves and potentially save their life, literally. My first patient, and I have seen this, and this is what's crazy. I was a brand new nurse in the emergency room, and I had a patient that came in incredibly hypertensive, marginally bradycardic, who was being straight cathed at home, and I missed it. And it's not that I missed it. I didn't catch the full bladder until far later, because when the family came in, they had said that they had been straight cathing and she was last straight cathed, 2 hours prior to arrival. So it escaped my head and my radar. And really what I should have done is I should have evaluated and said, well, here's the top causes for why, if I'm worried about the potential for autonomic dysreflexia, why this can happen. Like, where is this noxious stimuli coming from potentially, especially considering that she was hypertensive and bradycardic, and we knew she had a spinal cord injury. So at the end of the day, to wrap all of this up, right, autonomic dysreflexia is a fast-developing medical emergency that we see in patients with spinal cord injuries, and it has to be at T6 or higher, most commonly when either their bladder or bowel gets distended and then sends signals that they try to get to the brain that are inhibited and blocked at the point of injury, and that cause activation of the sympathetic nervous system to activate and go wild there, where they're then sending the fight or flight signals to all of the structures below the injury site. And that includes vasoconstriction in the peripheral vasculature, which causes that severe and sudden hypertensive state. And the carotid arteries sense that higher pressure state and tell the brain to drop the blood pressure. And the brain says, yeah, no problem. I'm going to do that by lowering the heart rate, and I'm activating that vagus nerve as the counter agent to initiate a parasympathetic response. And it causes the bradycardia, and it causes vasodilation of the vessels in the head and the neck, which results in the flushing of the face and headaches. So when you think about this largely, most common signs and symptoms are going to be that sudden increase in blood pressure, the decreased heart rate, flushing of the face, headache, and sweating. And what we do about that is, first and foremost, we have to drop the blood pressure. And the quick, easy thing, so long as there isn't any spinal precautions where you can't sit the person up, but sit them up to help with the blood pressure, right? It helps sort of drop some of that. It reduces the potential for that headache to be persistent. identify the noxious stimuli, assess that bladder, assess the bowel, look for tight clothing or for pressure ulcers or sores or some sort of painful stimuli that is being instigated on that patient. Because remember, if they have this spinal cord injury, they may not be able to feel all of those things, or it might be very distorted for them. And we try to remove the noxious stimuli, and if we cannot, that is an immediate call to the provider because we have to lower the blood pressure with some sort of medication at this point. So that's all that I've got for right now for autonomic dysreflexia. Thanks for listening to this episode. If this helped clarify any high-stakes components for you, share it with a friend. Make sure to share the show. It helps get the podcast out to others who might be looking for information like this or content like this. Feel free to leave a review or even just rate it. But until next time, go forth and keep on learning. Thanks for listening to this episode. If you've enjoyed what you've heard or enjoyed listening to these episodes, please make sure to rate and leave a review in the platform you're listening to it in. If you'd like to support the show, check out the podcast description for a link to the Nitty Gritty Nurse shop where you can purchase items. This podcast is meant for education and entertainment purposes only and is not meant to serve as medical advice. Please consult a qualified healthcare professional for advice. I strive to provide accuracy, but errors may occur and medications, protocols, and best available evidence may change over time.